Well, hello, everybody. Welcome to the March NF2 Meetup. My name is Connie Sorman, and I am the Senior Manager of Stewardship and Volunteer Development at the Children's Tumor Foundation. I wanted to just do a quick run through some housekeeping items before we jump right into our topic for this evening. We have closed captions available by a live captioner, and you can access those by clicking on the CC button at the bottom of your Zoom screen. They may also be in the More section if it's not showing at the bottom of your screen. And please mute your microphone unless you're speaking so everyone is able to hear the presenter. We welcome everyone to introduce themselves in the chat. Tell us where you're from and what your NF connection is, please. And then if we have time at the end, we'll have a Q&A, and you can put your questions in the chat during the presentation. Any questions we don't get to during the Q&A, we will follow up with you and get you an answer offline through email. So go ahead and use the raise hand feature or unmute yourself to ask a question when we're in the Q&A. So I would like to introduce Vidya Browder, who is on staff at CTF, and Vidya will introduce our guest for this evening.
Good evening, everyone.
All right.
Sorry. Okay, I hope you can still hear me.
Yes, you sound great. No more echo.
There's no echo, right? Sorry, I think I was connected on two places. Sorry again. And good evening. We are very privileged to have Dr. Gareth Evans as a presenter today. Dr. Evans is a professor of medical genetics and cancer epidemiology, and he's the chair of the department at the University of Manchester. He's published over 1,000 peer-reviewed original research publications and several reviews, chapters, and letters. He's the lead investigator on several multi-million-dollar or pound grants. He's also the leader of the Cancer Prevention Early Detection team at the NIHR Manchester Biomedical Research Center, also a lead clinician and breast cancer guideline group, and a long-term friend and collaborator and advisor of CTF. So we are very privileged to have Dr. Evans share his time and experience today.
Thank you. Would you like me to share the screen now then?
Yes, go right ahead. You can jump right into your presentation.
Right, so I'm going to talk to you a little bit about a national study that we've just carried out that is just about to be published. In fact, I think you can find it with the journal if you want to see the whole paper. It is an open access journal called Neuro-Oncology Advances. So my background, for those that don't know me, is as physicist, but also a cancer epidemiologist. So over the last 33 years, I've worked on NF, and NF2 was where I wrote my thesis, and basically describing the epidemiology of NF2 in the UK, and have written many papers since then. And one of the things that we're able to do in the UK very well is epidemiology, because we have good cancer registries. We're able to get follow-up on patients in terms of their survival, because through the NHS tracing system, we're able to check whether anyone is still alive. And the only way that we would not be able to do that is in country, and that doesn't happen very often with NF2 patients in the UK. So that's a bit of the background. So one of the reasons for looking into this is it's really been an unresolved question. Up until this report that I'm going to talk to you about, there had only really ever been single case reports of individuals with NF2 and those with sporadic vestibular schwannomas, so where they just had the vestibular schwannoma and nothing else, where there has been a description of malignant change within the tumor radiation treatment. And the number of reports is small, but about half of the reports are on patients with NF2, and that's sort of disproportionate compared to, because there are more than 20 times the number of patients with sporadic tumors that undergo radiation treatment than have NF2. There have also been occasional reports of malignant tumors in the radiation volume field, such as glioblastoma multiforme, but no systematic study. But we know that NF2 is a tumor-prone disorder, and that obviously people with NF2 have one faulty copy of the gene in their cells. Obviously, some have mosaic NF2, so it may not be in all of their cells. But one of the striking things is that there's never been a description in NF2 of a vestibular schwannoma becoming malignant without prior radiation treatment. And that suggests that this is not a normal thing to occur in NF2. So unlike NF1, where malignant peripheral nerve sheath tumors are relatively common, lifetime risk of 10 to 15%, there is no evidence to suggest that there is any increased risk in malignant peripheral nerve without radiation. So the way we carried out this study is to basically assess all people with NF2 in the UK. And I have kept a register of all patients in the UK since 1990. And since 2010, we've actually had 4 centers that look after all patients with NF2 in the UK, and I get the details of all patients from them. So we basically look after the follow-up of all patients with NF2. So cases in this study were NF2 patients who'd had treatment with radiation for benign tumors. So for vestibular schwannoma, the most common, for meningioma, or for ependymoma. And controls were NF2 patients who had not had radiation treatment, but had, at the same age, had a treatment for the same type of tumor. So either an ependymoma, vestibular schwannoma, or meningioma, and that treatment could have been bevacizumab treatment, or it could be that it was surgery to remove the tumor. So we have prospective data from when I started collecting it from 1990, with the addition of retrospective cases back to 1969. And we carried out an analysis called Kaplan-Meier, which looks at the cumulative incidence or the cumulative survival or not survival from a tumor. And outcomes in this study were the development of a central nervous system malignancy or malignant progression, where malignant progression was a 2 centimeter annualized diameter growth in the tumor. And then we looked also at survival from the index tumor treatment date. So in total, there were 1,345 NF2 patients in the UK, of which 200 had undergone radiation treatment. That's 133 males, so exactly the same number of males and females. Treatments had occurred between 1969 and 2021, with a median age, that's sort of the middle person's age at first radiotherapy, of 32.9 years. So quite a bit older than the average age of diagnosis. There were 9 subsequent CNS malignancies, stroke malignant progression, so 7 histologically proven malignancies, and 2 patients who unfortunately passed away with tumors that were rapidly growing. And they were identified in the 266 cases, but there were only 4 such occurrences in the control population of 1,079, and that was highly significant. We then looked at the lifetime and 20-year risk, and that was close to 6% in the irradiated group, compared to less than 1% in the non-irradiated population. And when we carried out the case control analysis, the controls were very well matched compared to the NF2 cases in terms of age at treatment, gender, and the severity, the genetic severity. And when we looked at that group again, there was a highly significantly increased risk. There were no malignant tumors in the control set. The 30-year survival from index tumor treatment was 45% for cases and 66% for controls, and that was also significant, although not so highly significant. So when we look at all of the patients here, you have all of the patients with no radiotherapy, and then the radiotherapy matched group, and then the radiotherapy group. And you can see here, they're matched for age, including the interquartile range. The median year of birth was exactly the same, so that takes into account date of treatment. You can see the median age at treatment was slightly younger, but not significantly in the matched cases. Again, the interquartile range. And then obviously matched for gender as well. There was slightly longer follow-up, and that's because there was slightly better survival in the control population. And that's the number of years of follow-up, 3,778 in the controls, nearly 3,000 in the cases, and then the mean follow-up time of treatment. So when we look at the actual cases, you can see in the no RT group, there were 0.46% of the population, 3.4% in radiation therapy, and only one of those tumors was not in the actual radiation field. The sites, you can see here predominantly vestibular schwannoma treatment as the first treatment, 42 meningiomas and 15 spinal tumors. And these are the actual malignancies. One of these epithelioid sarcomas was not in the CNS. It wasn't counted in the full analysis. It was in the knee area. There was one grade 3 meningioma that had the tumor prior to matching. And then 4 malignant peripheral nerve sheath tumors. 3 of those were in the vestibular region. 2 grade 3 meningiomas, a glioblastoma, and 2 aggressive ependymomas, one of which was grade 3. The other, unfortunately, we never got tissue because it grew so quickly. And these are the survival analysis. You can see here the median survival, overall survival there, and marginal significance there. When we look at the genetics, more of the control population had an identified genetic fault, and that was in all of the cells. Mosaics as well, but that's probably because we had tissue, whereas when you treat with radiation, you don't have tissue available. And we had more of the severe heterozygotes with the bad type of genetic fault in the control group. So in the matched population, as I said, there was no evidence that radiotherapy cases were more severe. The tumor size was likely higher in the non-radiotherapy group because we have a limit on tumor size in the UK of 3.5 centimeters. And there are certainly a number of NF2 patients who've had 4 and 5 centimeter tumors removed that would not have been eligible for radiotherapy. As I said, the genetic severity was non-significantly worse in the non-radiotherapy group, and there was therefore no evidence that radiotherapy is given for tumors that were already malignant. And this is a key point, because the radiotherapy treatment centers say, oh, well, the treatment was already malignant, but there is no evidence for that. And certainly none of the 3 tumors that became malignant were growing at a malignancy rate prior to treatment. So 7 millimeters a year is, relatively rapid, but it's certainly not what you would expect for a malignant tumor. So this is the Kaplan-Meier curves looking at the onset, and this is the 266 irradiated patients versus the whole rest of the population. You can see that's the difference in lifetime risk, and this is the time from treatment of the tumor. So we haven't had any malignancies after 20 years. You can see there's a run of the malignancies between 2 and 4 years, and so most of those are malignant change within an existing tumor. Most of these later ones are actually new malignancies in the radiation field, which is consistent with what we know. And this is the survival. You can see here the upper curve surviving longer, separating by about 15 years and staying separated. And this is the overall survival. So 2/3 of the non-irradiated group are surviving beyond 30 years from their treatment, which is getting on for 35 to 40 years from diagnosis, which is quite good. And then when we look at the vestibular schwannoma group alone, this is the difference again here, which is highly significant, close to 5% cumulative incidence of malignancy in the radiation group and nothing in the non-irradiated group. But the survival, although there is separation, is now no longer significantly different. So this is just looking at the vestibular schwannoma group. So there are a large number of cases. Unfortunately, not, the only current survivor from these malignancies is someone who was only diagnosed about a year ago. You can see here the delay here in terms of the progression. So up to 8 years here, but nearly all of these tumors were biopsied. You can see this one here, the schwannoma, had a typical response and shrank and then grew incredibly. There was no post-mortem. We have a number of 2 ependymomas that have had really bad responses. One was definitely frank malignancy, the other had malignant progression, and again, not something we tend to see with ependymomas without radiation treatment. So this is one of the case reports. This is the one that from the paper that's already published, and a number of these cases are already published, is this patient had treatment. You can see here that there's shrinkage of the tumor and then incredibly rapid growth to this very large size. And unfortunately, we were not able to get actual tumor because there was no post-mortem examination. So the risks with age, we think the risks are probably higher with people treated at younger ages. And this fits with the fact that particularly under the age of 18, the tissues are still dividing and growing. And that makes them more susceptible to acquiring genetic mutations when treated with radiation. So of the 32 patients treated in childhood, 2% had malignancy. Up to 23 years of age, it was 7.5%, compared to only 4 out of 199 after the 23rd birthday. So it does look as though it's much safer the older that the individual is. And that means that really we would be saying that we should have real caution about using radiation treatment in childhood. There is lots of data from the atomic bombs, from treatment with radiation in childhood to say that the risks are far greater, not only of causing a malignant tumor, but also of inducing meningiomas and schwannomas. Meningiomas and schwannomas that might not have otherwise occurred can be induced. And there are a number of very large epidemiological studies, not in NF2, that show that that is the case. So a proviso here is that I thought we had the largest series, but very, very recently, a big study has just been published in neurosurgery from radiation centers with 267 NF2 patients having 328 total vestibular schwannomas treated. They reported no evidence of malignancy. However, is less than 5 years, and only 20% of the patients have been followed up for more than 10 years. This is really the problem with radiation treatment centers. Firstly, without being cynical, you know, they get money for treating people with radiation, so they are likely to put the good side of the treatment forward. But the issue is that very few of these radiation centers give long-term follow-up. The patients are discharged back to their local center and not followed up in the radiation center. So the amount of loss to follow-up is extremely high, and you don't know what's happened to individuals. So it is a very large study, and it's contrary to what we've found. So I have to put it out there that, but our study is a whole national population with no bias, because we have complete long-term follow-up. And I would say, therefore, that we have to think that there is a real risk of malignancy after radiation. However, it's really important to say this is not enormous. If we take the 5% figure, it means there's a 1 in 20 chance that someone would get a malignancy, whereas that's 19 out of 20 will not. So the good side of it is that you haven't had a big operation, and operations that often cause more iatrogenic damage, loss of function. But in a world now where we have drug treatments that are coming on stream, that there are going to be new trials of drugs, which hopefully will be even better than bevacizumab at treating these tumors, I think we should be very reticent, especially about treating very young NF2 patients with radiation, when there may be maybe not curative treatments, but treatments which may completely ameliorate the condition. So the conclusions are that radiotherapy is associated with a 5 to 6% rate of malignancy or malignant progression. There has never yet been a report of a malignant vestibular schwannoma spontaneously occurring without radiotherapy in NF2, and that we really should be careful about using radiation under the age of 25. It should definitely not be the first line treatment in a young NF2 patient. I think there are instances where it's perfectly reasonable. In older NF2 patients who've had lots of surgery, they don't want any more surgery. That, you know, again, in older patients where it's the second ear and you want to try and preserve hearing as long as possible, where the tumor is growing and bevacizumab hasn't worked. But I think we need reticence here, and that reticence extends to proton beam therapy. So we've only treated 4 patients with proton beam therapy in the UK, and 2 of those have had very, very bad outcomes. I won't go into complete detail about it, but we don't think that proton beam therapy, even faster drop-off in radiation, is actually going to be the solution. I think we need better drug treatments and to limit the number of neurosurgical operations that NF2 patients require. But I think this is really important data because it is really the first real long-term whole population data on NF2 patients in a very large population of over 60 million. And this is what we see. So I'd like to thank especially our very large team of surgeons, neurosurgeons, oncologists, and research scientists in Manchester, and also the other services in the UK who provided quite a lot of the data in Oxford, Cambridge, and in London, and our fantastic NF2 team in Manchester. And that's the presentation. I'm sure there'll be lots of questions.
We had one question in the chat from Els in Belgium. I think you may have answered it toward the end of your presentation. She says she's a mother of a 9-year-old son with NF2 and wondering if that counts for all types of irradiation therapy, for example, proton, and we were told this was safer.
So I'm very reluctant to use proton. I mean, we did have a 9-year-old that had proton therapy who's now really in a very parlous situation. The original tumor shrank and did very well for several years, but everywhere around the treatment is now meningioma. And it's we can't say for certain it's the proton, but it's around where the irradiation was that the meningiomas have gone ballistic, not in the rest of the brain. So our radiation oncologist is certain that it is secondary to the proton therapy. And the other case that did badly wasn't a malignant progression, but it was treatment of an ependymoma in the spine, and that really didn't work out very well. It is in the paper. I don't really want to go into full details here. If you want to read about that, it is in the paper. So again, I would be very reluctant to say proton beam is the solution here.
Okay, we have another question from Laura. I have never heard of glioblastomas being a kind of tumor seen in NF2. Are these occurring because of radiation?
Yeah, that's exactly the point. So we wrote a paper 3 or 4 years ago saying there's never been a report of a glioblastoma NF2, and we in our database of over 1,500 patients with NF2, there has been no glioblastoma or high-grade glioma, not even a grade 3 glioma that's occurred in that population. The glial cell tumors you get in NF2 are ependymomas. They're very, very specific. We have seen a very small number of low-grade gliomas, very indolent tumors, but no malignant glial tumors. So we had one in our series, which was in an irradiated patient. And there is a case report as well, again, in an irradiated glioblastoma being in the radiation field. So although the lead time for our patient was only 3 years, it is still concerning that these are the only reports. And so these are not tumors that we think are common in NF2. They're maybe not increased over the general population risk. But you know, we would need tens of thousands of NF2 patients to prove that beyond doubt. but clearly they are tumors that can be induced, and that's why, again, I would say, and it's a very low risk with radiation. We've only had one, but I would still say concerned that we only have seen them after radiation.
All right. There is another question. Terry, you sent it directly to me. Do you want me to say it out loud?
Sure, I didn't mean to send it to you. Sorry about that.
All right. She says, or you can say it yourself, Terry, if you're comfortable.
Yeah, hi, my name's Corey, and I don't even actually know if I have NF2. I've had tons of genetic tests and they can't give me a real diagnosis, but I've had 2 surgeries. I have other tumors. I was just diagnosed with an acoustic neuroma, and everybody keeps saying, you should get radiation, you should get radiation, you should get radiation. But this has me convinced I should not. So I feel like I'm kind of at an impasse. Like I can just let them grow and die from them, or get radiation and die from them. It feels like we really don't have a choice here. So I'm kind of hopeless right now. And I'm sure other people are too, and just aren't saying anything. So I really don't know what to do with this information.
So, I mean, please don't say that this says no one should ever get radiation. I mean, radiation can work quite well. It, however, doesn't work as well in NF2 as it does in sporadic patients. Tumors tend to be what we call multifocal. They're bunches of different tumors. And that means that you don't necessarily treat all of the tumors well enough, because you tend to use radiation where you go for a lethal dose in the middle and then a marginal dose that is sublethal. So the dose very close to the periphery of the tumor mass is not killing. And that's the problem, that we think why NF2 vestibular schwannomas regrow more, so the control is much less than in sporadic patients, and that the malignancy risk is much greater. But, you know, it's hard to say. I mean, I don't know your specific circumstances. If you want a certain diagnosis, because a lot of NF2 patients with no family history are mosaic, and it is not possible to find the genetic fault in blood. You do the genetic analysis on the tumors, and if you identify an identical NF2 genetic fault in both tumors, that proves you have mosaic NF2. Now, I would think the risks with malignancy are less in mosaic NF2, but we don't have definitive information on that. Again, I don't want to say, look, this is a massive, massive risk. It's 1 in 20. So it's 19 in 20, it won't happen to you.
And Dr. Evans, I don't know if Corey mentioned it, but she's 38 as well. So she's outside of
Yes, so I'd say it's down to maybe 2%. So that's 49 out of 50 that you, 49 out of 50 you won't get it. So again, don't throw the baby out with the bathwater. It is still a possible treatment. As you're older, it's probably less risky to do it.
So Terry also had a question that came directly to me, and I have permission to read it. Terry from Texas, I read somewhere that any radiation, for example, from X-rays, can cause tumors to form. My physician often orders X-rays. Is that correct?
So, I mean, with dose of radiation, so we would say that you should probably try and avoid regular CT scans. MRIs don't involve X-ray irradiation. So in NF2, we would say always do an MRI unless it's an absolute emergency. And nowadays, we used to be a problem with auditory brainstem implants and cochlear implants because of the magnet that's used. But nowadays, we can get compatible brainstem implants and magnets. You can do head wrapping, and we can still do MRI scans. So absolutely you try and avoid having regular CTs. X-ray, like a chest X-ray, I really wouldn't worry about that in NF2. It's really where you're irradiating the region where you get the problem, and that's the brain. So try and avoid regular CT scans, although CT scans nowadays do have a little bit less radiation than they used to.
Okay, Brittany also has a question. Throughout your studies, did you follow patients' hearing preservation with radiation versus without radiation?
Yes. So, I mean, again, it's difficult to we don't have control data. I mean, with surgery, unless you go to very few centers, surgery, we normally it's, the hearing goes. There are some surgeons with small tumors that can preserve hearing. Now, the real question is, if you don't irradiate, does the hearing last any longer than if you do nothing? And what we see is that a small number of patients lose the hearing immediately, and that's particularly likely if the hearing's already substantially reduced. But actually, very few patients with radiation have serviceable hearing 10 years after treatment. And the reason for that is that the blood supply to the cochlea is very, very delicate by the radiation. And so we do have a very small number, maybe 5 to 10%, that have very, very long-term hearing preservation, sort of out to 20 years. But the great majority lose the hearing between 5 and 10 years. And that may be no better than if you did nothing at all. And probably the only situation is a tumor that's growing relatively rapidly, that if you didn't treat it, the hearing would have gone more quickly. But for slow growing tumors, particularly with the possibility of new treatments around the corner, with the Intuit studies, the NF2 Intuit study, and the basket studies that are going on, I would really hold off having radiation if you've got a very slow growing, and particularly if your tumor is stable.
So back to the question about X-rays. There was a question concerning dental X-rays. Is that too close to the brain? Should people avoid dental?
Yeah, I wouldn't worry too much about dental X-rays. I think the radiation to the meninges or to the vestibular area is going to be small. Maybe the orthopantograms, the zip X-rays that go all the way around, you might get a little bit more, but I wouldn't be too concerned about dental X-rays. Really, it's just CT scans.
Okay.
So yeah, there is a question there I saw about the cochlear nerve preservation, and yeah, it's absolutely true that radiotherapy, you can preserve a cochlear nerve, and a lot of the deafness, as I've said, is from the blood supply to the cochlea. So we have put in successfully cochlear implants after the hearing has been lost in patients with radiotherapy. So certainly we can get quite good hearing rehabilitation in many patients after radiation. So that is a plus, if you like, for if you do lose your hearing after radiation treatment, that often the cochlear nerve itself is still functional. It's the blood supply that's killed off the cochlea that's the problem, and you can put an implant into the cochlea and get some hearing back. But it needs to be done relatively soon after loss of hearing, because you lose the plasticity otherwise, and the brain just forgets how to deal with the input of signals.
And the last question was about dental X-rays, but I think you covered that.
Yeah, I really I wouldn't worry too much about dental X-rays.
That's what we have in the chat so far. Any other questions?
One just came through, Connie,
I see
from
that.
Terry. Yeah.
My VS was rapid growing. It was surgically removed, but I had meningitis twice afterwards due to CSF leak and had multiple CTs. My physician does not do regular MRIs. Should I get 1 year?
Yeah, you should definitely have MRI instead of CT in NF2. If you have NF2, you shouldn't be having regular CTs. I mean, the only situation in NF2 where you would say you don't need annual MRI is where you're older and either the tumors have all gone or they're very, very stable over a number of years, and you could push it out to two years, maybe 3 years. But certainly in younger patients, it should be at least annually. And while there are growing tumors, it should be at least annually.
In what circumstances would you say brain MRIs are indicated more often than annually?
Well, we actually do on bevacizumab because we want to see how quickly the tumors respond and whether they're responding. So we do a scan at 3 months and then at 6 months, and then we titrate we titrate that with the treatment. So we certainly do it more. We would also in the first follow-up scan of someone diagnosed, we'd probably do a 6-month scan just to check if anything's growing rapidly. So, and after that annually. And in children, often we would do more than an annual scan. But that's the brain. We would usually not do spinal imaging more than 3 yearly unless there was significant spinal disease. And it would definitely be MRI.
Okay, and then what about familial schwannomatosis? As someone whose diagnosis is ambiguous, have any studies been done for these patients?
So in terms of familial schwannomatosis, if you have multiple schwannomas not affecting the vestibular nerve, and you have a parent who has multiple schwannomas, again, not affecting the vestibular nerve, that is not going to be NF2, I can say for certain. Schwannomatosis where you don't have the vestibular nerve affected, but you're the first in the family to be affected, that can be mosaic NF2. Now, in terms of the other conditions, we really don't have information on malignancy following radiation treatment, but we do know that MPNST, there is a significant risk, in SMARCB1 related schwannomatosis, there is a significant risk of MPNST with or without radiation. So I'd be very, very reluctant if someone has SMARCB1 to use radiation to treat their benign tumors. LZTR1, we just don't have the data. But I haven't seen, we've got 7 LZTR1 patients. I've not seen malignancy in them, and I've not seen it reported in the literature. Whereas with SMARCB1, we've got 5 patients in our data set who've had MPNST, and that occurs spontaneously, like it does in NF1.
Is there any concern with radiation from AirPod? Excuse me, AirPods or holding a cell phone to the ear?
So, I mean, there's been a lot of work done on cell phones. I think there isn't any convincing data. The radiation you get isn't X-ray radiation, so it's not the sort that causes mutations that we know in cells. No really convincing evidence that cellular phones cause vestibular schwannomas. There's been lots of subjection about it and queries about it, but there is no convincing evidence. So it's really only X-ray or proton radiation where it's potentially a risk of inducing new tumors or inducing malignancy in NF2. Okay.
All right. Well, thank you so much, Dr. Evans, for presenting tonight. This is
so I hope, you know, I mean, some of you will have had radiation treatment. I hope I haven't frightened you. The important thing is, particularly if you're older, the risks are not massive. And, you know, the information needs to get out there so that we give the right advice to people in the future. And, you know, I'm definitely not saying radiation treatment should never be used. I think there are a number of situations where, you know, it absolutely should be on offer. But you know, as I said, the very young, unless there is a really, really important reason to do it for a benign tumor, I really wouldn't use radiation in children.
Okay. Well, thank you so much. And we know it's quite a bit later where you are in the evening. So
well, I hope I haven't been too unpopular.
Thank you for taking
not necessarily the best message to pass on.
But important for people to have.
Okay, everyone.
Thank you.
Thank you. Thanks very much.
Good night. Just in closing, I'd like to mention that we have a couple of events coming up that you may be interested in. And if you're interested in these NF2 meetups, we have a calendar of events planned for the next couple of months. I just dropped a link in the chat so you can access that calendar. And then you'll continue to get emails and notifications through our NF registry as well. We also have the NF Conference and NF Summit coming up in Scottsdale, Arizona in June. The NF Summit is a patient and family event, and the NF Conference is for our medical community. The NF Summit is June 21st to the 24th, and you can find all the information you need about that at nfsummit.org. And then the conference information is available at nfconference.org. So I'll drop those both in the chat as well. And if you have any questions about anything related to being an NF2 accelerator or these events, please get in touch. We would love to help you out. Thanks, everybody. Have a great night.
Bye. Thank you.